Everybody, we'll get started. Welcome to American Heart Association's Get With the Guidelines CAD webinar series. These educational webinars are being brought to you by the Southwest Affiliate Stroke Committee. For a full list of all the upcoming webinars, visit www.heart.org/SWA-Quality. Before we get started, we would like to go over a few housekeeping items. To avoid background noise, all lines have been placed on mute. For questions, you can unmute your line by pressing *6 or type in the Q&A section of WebEx. All slides and handouts will be sent to attendees within a week of the call. Please also visit www.heart.org/SWA-Quality to view the recording of today's webinar. At this time, I will turn it over to Lonnie Den, Regional VP of Quality and Systems Improvement for the American Heart Association, to introduce today's speaker.
Good morning, everyone. I just want to do a quick sound check. Ben or Kristen, could you come off mute by hitting *6 and let us know if you can hear us okay?
Hey, Lonnie, this is Ben. I can hear you just fine.
Okay, perfect. Thank you.
Yeah.
Hi, this is Kristen.
Great. Thank you so much. I'm Lonnie Den. I am the Regional VP for Quality and Systems Improvement and Mission Lifeline for the Southwest Affiliate. I'm going to kick off the webinar, and then I'm going to pass it to Ben to talk about EMS and Mission Lifeline, and then Kristen Waller is going to finish up by really talking about the details of Get With the Guideline Coronary Artery Disease, the registry itself, how to run report, how to receive recognition or keep your recognition. So I just want to thank everyone for taking the time to join us for this discussion about the American Heart Association Get With the Guideline Coronary Artery Disease and Mission Lifeline initiatives today. As I said, the webinar is being hosted by the Southwest Affiliate. The American Heart Association and our staff covers the states of Arkansas, Colorado, New Mexico, Oklahoma, Texas, and Wyoming. Next slide, please. Thank you. I wanted to provide an overview of our suite of quality initiatives. This slide that you're looking at now provides a snapshot of all of our programs. We have Get With the Guideline Stroke, Heart Failure, Resuscitation, AFib, and Coronary Artery Disease Quality Initiatives for hospitals. A Mission Lifeline program for communities that provides the recognition for eligible EMS agencies and hospitals, as well as cardiac accreditations for hospitals, and target blood pressure and cholesterol programs for clinics. So what is Get With the Guidelines? We have this tremendous body of science and research that feeds the patient care guidelines, but putting it into practice in the real world can take a very long time. So our programs help speed up the time that it takes to bring the guidelines to the bedside. We offer the data collection tools that allow hospitals to track their guideline adherence. And we heavily subsidize the registries to make it more affordable for hospitals to participate. And we provide multiple opportunities for you to market your work if you are providing guidelines-based care. Slide, please. So we are so very excited about our most recent Mission Lifeline program change. Get With a Guideline Coronary Artery Disease is the new data source for Mission Lifeline moving forward. Get With a Guideline CAD is what we call it for short, supports our Mission Lifeline systems of care work that involves EMS providers, referring hospitals, and receiving hospitals. Previously, the Action Registry was the data source for Mission Lifeline, but we will no longer be using the Action Registry data for Mission Lifeline. Moving forward, Get With the Guidelines CAD will be the sole data source for Mission Lifeline Hospital Report, Mission Lifeline Regional Report, and Mission Lifeline Recognition. Next slide, please. With the release of Get With The Guidelines CAD, we are able to provide Mission Lifeline hospital and regional reports and analysis for Mission Lifeline recognition in real time. There will be no more waiting for quarterly reports to drop months after after the data is relevant, and no waiting for weekly data uploads. The instant your patient data is entered, you are able to run your report, and the patient data is reflected in the report. This year marks the 10th anniversary of Mission Lifeline. We have been working with doctors, nurses, paramedics, departments of health, and other healthcare professionals in communities throughout the country for the past 10 years to coordinate heart attack and stroke patient treatment. Since the American Heart Association started this work, regions and states have decreased the time it takes to get patients to hospitals, to route them to the most appropriate hospital, and ensure that each patient is treated based on the latest research when they arrive. Thank you, and congratulations to everyone that has been involved with Mission Lifeline in the work over the past 10 years. So the pricing for Get With The Guidelines CAD is in front of you. It's completely free in 2017. It will allow you, the tool will allow you to have full functionality to pull your real-time Mission Lifeline reports and measures, and Kristen's going to go into in more detail later in the webinar. If you're able to enroll by November 1st, you receive a $500 discount on the 2018 annual enrollment fees. There will be no additional charge for the chest pain accreditation data layer and report. And there's a 50% discount for critical access hospitals and a 10% discount for corporate health systems that enroll 10 or more sites under a single invoice. Pricing options are listed here. Under option 1, you'll see that it's for hospitals who wish to directly enter their patient data into the online tool. There's a $500 discount for early enrollment. It will be for 2018, $2,750, and for those hospitals enrolling after November 1st, $3,250. For hospitals that choose option 2 and data entry via vendor, we're providing an additional discount so that we realize that hospitals will most likely have a fee associated with a vendor upload, and so we wanted to pass on a little bit of savings to you by offering an additional discount. $2,500 before November 1st and $3,000 after November 1st. We have a third option for hospitals who want just one quarterly report, a snapshot of how their hospital is performing, just once a quarter, or the regional report once a quarter for regions that are utilizing the tool for their regional STEMI data. That will be free if the hospital enrolls in that option before November 1st and $500 after November 1st. How to enroll? So we've made it really easy. There is a website where you can just do everything online. You just click on the Enroll Today tab, go through the agreement, and make your choices, and then you'll receive an email from the third-party vendor who runs the Get With The Guideline CAD registry to welcome you into the system and to set you up for training so that you can start entering your patient data. The URL is listed here. You can also just Google Get With The Guideline Coronary Artery Disease, and it will pull up that way as well. The vendors that have already applied and been approved for Get With The Guideline CAD are listed here, and we have many additional vendors. If you don't see your vendor here on the list, know that we have many additional vendors who are in the process of signing up to become approved vendors. And I wanted you to be aware of an exciting announcement and update that we received recently about our tool being an approved data solution for chest pain center accreditation. It's offered by APC Accreditation Services, and also want you to be aware that we do have accreditations that we have partnered with the American College of Cardiology on cardiac accreditations. One is our Mission Lifeline accreditation for hospitals, for receiving centers or referral centers, and the other one is our newest accreditation, and that is a CVCOE, or Cardiovascular Center of Excellence accreditation, that is in partnership with the American College of Cardiology. And with that, I'm going to pass the baton to Ben Leonard. He is a paramedic, and he is Director of Quality and Systems Improvement for Wyoming and New Mexico and El Paso.
Excellent. Thanks, Lonnie. Great presentation, and really appreciate the highlights. You can go ahead and go to the next slide, please. We thought it would be valuable today to really encompass the systems of care component, to include the EMS side of things, just so we can pass the information along to the hospital counterparts, which are, you guys are on this call, just to see what exactly is entailed with the EMS component for the recognition and then Mission Lifeline participation. So this first slide is just a little snippet of the history. As Lonnie mentioned, we are celebrating our 10-year anniversary for the Mission Lifeline program, launched in 2007. In 2001, the American Heart Association was partnered with the Action Registry. 2011, we were using the Action Registry Get with the Guidelines as a data source for the Mission Lifeline reports, but as Lonnie mentioned, and Kristen will go into greater detail, that change has happened recently. We're now utilizing the Get with the Guidelines Coronary Artery Disease Program for the data used for Mission Lifeline. And so we're really excited for that, for those highlights that Lonnie had mentioned. There's a lot of the hurdles that were faced by the EMS agencies and the hospital counterparts in terms of, timeliness of getting the data returned to being usable in the system meetings. So really, really exciting news for that. The hospital recognition offered in 2010, and then EMS recognition was offered subsequently in 2014. You can hit the next button, please. The EMS recognition and the hospital recognition was really focused, the EMS recognition was really focused along the guidelines that were announced in 2013. And I'm sure we're all familiar with this, where all communities should maintain a regional system of STEMI care that is, as it states out, the assessments, quality improvement, as well as performance of 12-lead ECG in the field by EMS personnel. As you'll see here in just a second in the high-level overview of the required measures for EMS recognition, most of the measures are focused around these two recommendations, which, as you can see, they're Class 1 levels of evidence B for both of these. So it's really, really important and beneficial for communities as well as EMS agencies to grasp the concept of Mission Lifeline and move forward with improving the outcomes. Next slide, please. As you can see, so this is kind of a busy slide, and I apologize, but the required measures for recognition really kind of determine on the capabilities that the hospital has that the EMS agency is transporting to. So if their primary transport location is a STEMI receiving facility, the EMS agencies are required to report on the 4 measures in this box here for the STEMI receiving. As I mentioned earlier, 3 of the 4 are really focused around acquiring that 12-lead ECG, more or less screening our patients for the ones that are having a STEMI. And the final measure is really the system measure of how well we're functioning as a whole with our pre-hospital times as well as the hospital times, and even segmented into the in-hospital times between the emergency department length of stay. Yes?
I'm so sorry to interrupt you. We are, your reception is a little cloudy.
Okay, I'm sorry. That's okay. I apologize for that. Is this any better, Lonnie?
It is better.
Okay. Just
right where you are.
Exactly. I'm not going to move now. I'm going to hold this position, see how well my cell service remains. So as mentioned, the measures for recognition really depend on the transport destination capabilities. This is a busy slide, and I do apologize for it, but as you can see, the majority of these measures the EMS agencies are required to report on and be consistent with are focused around 12-lead ECG acquisition. That if you just take a quick look at the STEMI receiving box here, the first measure is improving the number of patients that, or increasing the number of patients that receive a 12-lead that could be consistent with STEMI. The second and third measure really is what they do after they have that 12-lead or have that case identified, first medical contact to 12-lead acquisition times, and then once they receive or have a positive STEMI show up on their EKG, how long is it taking that EMS provider to activate the receiving facility and get the CAD team notified and mobilized, if you will. And then the final measures is looking at the total system performance, our reperfusion times, if you will. First medical contact to device in 90 minutes or less. Of course, that's a measure that you hospitals, I'm sure, are very familiar with. The EMS agencies have a massive component and some buy-in with that, and so it really is a system goal. So we really want to focus on that. The STEMI referring facility, same thing, but they're looking at their thrombolytic times for those patients to get thrombolytics instead of transfer for primary PCI. If in those situations there's an EMS agency that transports to both a STEMI receiving and then a non-PCI facility, they have to report on all of these measures. The first medical contact to device for those patients that go to a PCI facility, the door-to-needle times for those patients that go to a non-PCI facility, as well as the EKG measures. Like I said, I do apologize for the busy slide, but there is quite a bit involved with this program, and it continues to expand. We've got a couple slides here showing the previous years with it. Okay, next slide, please. All right, so as the Mission Lifeline EMS recognition program continues to evolve, the platform for that is if we have new measures that come up within our committees, they're usually introduced in an optional or reporting measure, something that's not required, but it gets the wheels turning on the EMS side of things in terms of what they need to start measuring. Our plus measure is one that adds that added layer of recognition, and for this year it is the plus measure that's listed, or the measure that's listed in the out-of-hospital cardiac arrest. So as you can see, the evolution of EMS recognition is really starting to expand and go beyond just the patients that are presenting with the ST-elevated MI. We're looking at the out-of-hospital cardiac arrest. What can we do to help impact the outcomes of those patients that the EMS sees prior to arrival? And of course, with this one, you know, if we are able to get the cardiac arrest into return to spontaneous circulation, have that sustained for 20 minutes, we want to then go we want to then start digging for the cause. And so getting the thought process going, and we want to see if it is cardiac in nature, so they could, the measure really specifies on getting a 12 lead in those cases. But as you can see, the disease process, if you will, emergencies, we're expanding into the stroke, the non-STEMI, or the acute coronary syndrome field. So it is evolving. This is, I think we've had changes almost every single year that the program has been out, and which is great, and we're looking to expand and hopefully get those EMS agencies on board with this stuff. If you would go to the next slide, please. And this slide kind of goes in with some of the hurdles and the challenges that EMS agencies face with the concept of recognition and the concept of QI processes or practices on this scale. Change I put in the center of this just because that's, we've all been in healthcare long enough to know that change is not necessarily good, at least initially, but the changes usually happens and it does have benefit in the long run. It's just making that connection. So traditionally, and as Lonnie mentioned in the intro, you know, I've been a paramedic for a few years, and when we talk about QI processes, at least in the services that I've been in, and there's differences wherever we go, but when we talked of QI processes in the pre-hospital setting, it was really focused around chart review. You picked a couple cases throughout the quarter or the month, and the person that was attending or taking care of that patient organized the presentation, and they really just kind of went through the chart with a fine-tooth comb, which is fantastic. and it's a great educational opportunity. But in terms of QI processes that we're doing on this level, in terms of performance outcomes and systems of care work, this change has been relatively challenging, and a lot of it has to do with the method in which the data sources are utilized. For an example, as I mentioned in our measures and the requirements for the measures, the 12-lead ECG and the placement in the electronic patient care records, there's so many different locations that you can actually put treatment as a 12-lead ECG. And so standardizing documentation practices has been one of the biggest hurdles that our folks have been faced with. In addition, for the data sources, there are many vendors. Lonnie had that list in her talk about the different vendors used for EHR and the upload features. Pre-hospital world is the same setting. We have different vendors out there, all of them what we call NEMSIS compliant, which means they utilize the same data definitions for their fields, but every one of those is relatively unique. The data sources and the way that EMS agencies apply for Mission Lifeline is it's a manual data mine to go through these cases to identify the age groups, identify if they're related to trauma or not, narrow down their chief complaint. And once you have that, then you've got to go through and start filtering through their treatments. And it's a pretty painstaking process. I've worked with a few of the EMS agencies on getting this stuff done. We do have tools that are available, but with the uniqueness that presents itself with our data sources, the fix is just as unique. There's not a cookie cutter fix for our challenges faced with the data sources. For recognition, once again, they can get so much information from their data sources, but where the need and some of the challenges, once again, that are faced by our EMS agencies is getting that system-level measurement or system-level metric from the hospital. And so, getting the times, the reperfusion times, the cath lab times, if there were non-system reasons for delay, which are applicable in the pre-hospital setting. So that's been one of our biggest challenges in getting our EMS agencies involved with this, which is where we're, putting our ask out to you guys. And if you would go on to the next slide, please. The utilization of the feedback with the performance that the EMS agencies do with our STEMI cases is so vitally important. And I will throw a footnote onto this. We talk a lot about recognition and the value that goes in with that, but I think the actual award is really the icing on the cake. And if we're able to get the award, that means that, and we all know this, but that means that our care that's being delivered both in the pre-hospital setting as well as the hospital setting is where it needs to be. And so it is very, very important that we get more and more of our EMS agencies and as well as our hospitals involved with the recognition program. And the best way to do that is to identify our opportunities for improvement, and this form really kind of helps with that. The way that this is just an example here that was utilized in one of our statewide projects, but pre and post cath pictures, very quick breakdown of what was going on with the case, the culprit ECG, the case synopsis, and then importantly the timeline down at the bottom. And so being able to take this information back and do the QI processes on that case-by-case or chart review is so important, and we really highly encourage that practice to be adopted in your facility if it has not yet been done so. As you can see with the next slide, in the Mission Lifeline program as it's evolved over these last few years, could you hit the next slide for me there, Audrey? You can see that the number of our EMS agencies and their participation and the trending that the uptake in this program has just been fantastic to watch and be a part of. Breakdown of this graph, we have on the far left graph, the three bars there, the blue is 2014, the gold or orange is 2015, and the gray is 2016. As you can see, each one of the years, we've seen a massive increase in our participation as well as our number of awards. The one that you see the kind of downturn where the gold is higher than the gray is in 2015 compared to the 2015 for silver or gold and silver. When in 2014, this was our first year of awards, and there were very few gold awards. But so we've obviously, as soon as we had the opportunity for our EMS agents, the number of agencies represented with recognition, that far right bar graph has just grown by leaps and bounds, and it's really, really exciting, and we hope that it continues. And as you can see, the importance of its continuing is really based upon that collaborative effort between the hospitals and their EMS agencies, because as we ask more and more of our EMS agencies, that collaborative work between the two disciplines is going to grow as well. Final slide here, just one of the greatest jobs or parts of our job is being able to recognize our EMS agencies and get out into the community, present the award, as well as do kind of a highlight to the decision makers within those organizations. Just one more slide, please, if you don't mind, Audrey. Thank you. And that's, like I said, this is really the best opportunity, whether irrespective of the type of service, whether it's hospital-based, community-based, fire-based, getting out there and putting the spotlight on these crews, as well as the hospitals that they work with, is just one of the most rewarding and gratifying parts of the job. And so we really thank you all for what you do, and by all means, let us know if there's anything we can do to help you. And with that, I'll kick it over to Kristen.
Thank you, Ben. Hi, everybody. I'm Kristen Waller, and I'm the Quality and Systems Improvement Director for Arkansas. Audrey, if you could go back just one slide, and I'll give a little bit of my background. The bottom picture is actually the facility where I worked at before. I was a chest pain STEMI coordinator. I have some background in the cath lab, cardiac rehab, as an abstractor. So in this picture, you'll see both of our EMS agencies in our county and our hospital with all of our Mission Lifeline awards. And so just to point out, this really is a system of care approach. It all started with our county EMS. He worked hard to obtain his Mission Lifeline awards, and then the hospital got on board, and the city fire department ambulance. And so we were all able to work together to achieve better patient outcomes, and in the process receive awards and recognition. Okay, next slide, please. And you can go on one more, please. So I want to talk to you today about the benefits of Get With a Guideline CAD. As I said before, I've abstracted for the Action Registry, announcing the CAD Registry, so I want to point out some of the benefits of CAD today. But also, one of the benefits would be continuing participating in Mission Lifeline, achieving award status. We have QSI field staff available, ready to answer questions, to help, to come to your site and visit. We now have real-time reporting available and super user function availability coming soon. Next slide, please. So this is just an example of what our awards look like, the icon that you would receive to use with your hospital. There's awards for EMS, for the referring center, and also for the receiving center. Next slide, please. Some of the recognition that we have. Here's a picture of the U.S. News and World Report magazine. We are able to provide you with a marketing toolkit for your hospital that you could use on Facebook, so your marketing team could put that out, your nurses, your cardiologists, anybody who wanted to spread the news in your community that you have been recognized in the U.S. News and World Report. And also on Twitter, it's available there too. Once you go into that, when you click on it, you can click on your state, and it will actually show all of the hospitals that made award status this past year. Next slide, please. For our hospitals that achieved silver or gold status, they are recognized at scientific sessions, and so that's exciting. There's a reception there for those hospitals. They get an invitation, and you can come out to California this year and be recognized. Next slide, please. So this year, in order to achieve recognition for 2018, you only have to enter 1 quarter of data and to get with the guidelines CAD. As Lonnie said earlier, it is free to enter data in 2017. If you want to achieve Mission Lifeline status or maintain the current award level that you have, then you only have to enter 1 quarter of data. You do not have to worry about entering the entire year. You can enter 2 quarters of data and to get with the guidelines CAD this year in order to increase your award level status for 2018. There is not a deadline as far as entering quarterly, but the ability to enter 2017 data will end in March. So you do have until March to enter data for 2017. And we certainly encourage you to enter on a regular basis so that you can see how you're doing and fix problems as they arise, issues, and address it as you go. Next slide, please. Here's just some examples. If you've never participated before in Mission Lifeline in the Action Registry, then you would need to enter 2 or more quarters of data to achieve bronze or bronze plus, silver or silver plus. Or you could do 1 if you're just trying to obtain bronze level. If you participated in the past and you were gold or gold plus, then you just need to enter 1 quarter of data to continue having your gold or gold plus status. So if y'all could just look at the examples on that slide right there and see what you would need to do in order to either achieve status or if you want to maintain or increase. But only 1 or 2 quarters of data are required for 2017 for recognition in 2018. Next slide, please. Real-time reports are available now for all of the measures. If you're a receiving center, you can enter your data, and we'll look at the primary PCI time as less than or equal to 90 minutes. Your EMS first medical contact primary PCI, 90 minutes or less. Making sure you get your aspirin at arrival and discharge, your beta at discharge, your statin, smoking, and then if they are coming from a referral center to your receiving center, then primary PCI in less than or equal to 120 minutes. Now, we also have the availability for referral centers to enter their data as well, and for them, we're looking to see if they were able to do an ECG within 10 minutes of arrival, if they give thrombolytics, if that's done within 30 minutes, and also the focus would be on door in, door out of 45 minutes. So we want them to quickly transport to the receiving center. So that is one of their measures. The aspirin at discharge, the beta at discharge, the statin at discharge, and the smoking cessation for referral centers do not apply if you transfer them out to a receiving center for PCI. So if you keep the patient at your facility for whatever reason, then all of those would apply. But if you're a referral center and you're transferring them to a receiving center, then obviously our main focus is you get the EKG with thrombolytics if they can't get PCI within 120 minutes, and then you get them door in, door out in 45 minutes so that you can quickly get them to the PCI center. And then we also have real-time reports for non-STEMIs as well. Next slide, please. Something that we've started is what we call data days, and so quarterly we will send each hospital that's participating and get with the guidelines CAD a snapshot of their data and where they stand as far as award status and how they're meeting their measures. Now, it's not final. Like I said before, you have time to enter your data, but it's just going to be where you are at that particular time in the quarter, let you know how things are going, where you need to focus. And then 2 weeks after we send out that data, we have what we call quality exchange. And so everyone in our affiliate calls in, and you can ask questions, we have advice, best practices from other hospitals, you know, what they've done to make something work that they're having trouble with. So it's just a time to come together and share what's working for us, what's not, you know, what questions we might have, things that we need to fix. So our next data days where we send out those reports will be in October, and then on Thursday, November the 2nd at 8 a.m., we will have our quality exchange, and that's a conference call. Next slide, please. Okay, so this is what Get With The Guidelines CAD looks like. Your hospital may already be participating in maybe stroke or AFib or heart failure, but there is a tab. They're all there at the beginning on the community page, and CAD is there. You'll see on the right there's a legend, and so the little circle with one person is new patient, and you click on there to get started. If you want to see all of the patients you've entered, then there's an icon with two people in the circle. And then the next one is reports, and then the next one is resources. So there's 4 tabs there that you can click on, and then there's also training available. You just click on those tabs as well. Next slide, please. And in order to click on a real-time report, which as soon as you have entered a patient, you can go in and create a report. You don't have to wait. It's automatically available for you. But you have the availability to run reports by year, by quarter, month, day. You get to check in the boxes and select which ones you want to do. You can run it by certain measures, like if you're having trouble with door to PCI, or maybe it's a beta blocker at discharge. Whatever it is that you're wanting to run, you can run that. You can choose how you format it. If you want to compare to your state, to your region, you can do that as well. You do not have to wait until the end of the quarter or whenever the reports are released to you. You can go in and do that yourself. And also you can build and save reports. There at the bottom you see the tab that says Add Another Report. You can save it right there and compare and go back to it and have it available for you. So you are able to create these reports for what you need, what your hospital needs. Next slide, please. So here is an example of a regional report, and of course it's blinded. There's 3 different hospitals here. We do require that there be 6 hospitals in a region in order for there to be a regional report, just to keep things blinded and hospitals unable to guess who is who. But if you do not have 6 hospitals in your region and all hospitals are agreeable to be in a regional report, then that is a possibility there. But that's just a way to show how you're performing, how other hospitals are performing, and let you know what you need to work on. And so this can be exciting. You know, if you feel like your hospital's performing exceptionally well, and you could take this to your cardiologist and show them that you really are, and you know, it's an exciting thing to be able to provide. Next slide, please. Like I said, super user accounts are coming. You would be able to look at statewide reports, regional reports. There are some hospital systems that own several hospitals in the region, so a super user would be able to go in and compare all of their hospitals. And next slide, please. Also, I'll just mention this, you don't have to go back, but you know, if your health department is interested, a super user account would be a good thing for them where they could go in and look as well. So this is showing real-time measure calculations, and what I did was I went in and entered a patient, and you'll see that the measures tab is the one that's highlighted, but you have an admissions tab, a pre-hospital arrival tab, there's a hospitalization tab, and then there is a discharge tab. Well, before you actually submit that patient, you are able to run the measures right then. So you click on Calculate Measures, and this is what comes up. So this patient met all the measures that applied to them. They received their aspirin at discharge, the beta blocker at discharge, their statin, and they happen to be a door-in, door-out to balloon in less than 120 minutes. And so they were compliant with that measure as well. So the other ones that are grayed out, they're automatically excluded because it did not apply to them for that particular patient because they were a door-in, door-out to balloon. Next slide, please. So here's another example of a patient that I entered, and then I selected Calculate Measures before I actually submitted the patient. And so now I'm seeing red. This patient fell out. So they didn't get their statin at discharge. They didn't get their ACE at discharge. Everything else went well, but that didn't. There's actually an Errors tab to the right of your screen as you're entering patients. You can click on that, and it will let you know as you enter patients, if you've missed something or something didn't add up, something wasn't quite right. So it will actually let you know as you go. You don't have to submit the patient and then see, if something fell out. So when I calculated measures, those things came up. So I wanted to know, why or what happened. So next slide, please. So before I submitted the patient, I looked and I saw where their EF was 30. So they should have received an ACE or an ARB, and they should have received cholesterol medicine before they left as well. So this patient that I put in as yesterday. So what I would do next is I would take that and go directly to the source. I would go to the cardiologist or the hospitalist or case management or somebody and say, hey, we recently had this patient. They didn't get their medications on discharge. We need to fix this. Is this a system problem where we can, have some hard stops where we discharge a patient where we have to select, that they need these medications? Do we need to educate some more? Do we need to educate nurses to ask, say, hey, do we want to send them home on these medicines? But you could go fix the issue sooner rather than later. In the past, when you received quarterly reports and you weren't able to realize this right away, it's hard with staff turnover, with physician turnover, to be able to go back and say, hey, 3 to 6 months ago, you forgot to prescribe such and such on discharge. So, we need to, from here on out, we need to make sure they get their ACE or the ARB or their cholesterol medicine or whatever it may be. And so you've gone 3 to 6 months without taking care of the issue, and now you can fix it right then. Next slide, please. And there is a way to do patient drill downs as well. If you want to go in, there's a patient list. You just click on that, and you can look at it by patient. Next slide, please. And then there's filters for comparison. So maybe you do great Monday through Friday when the cath lab is there, when everyone's available. Maybe it's Saturday or Sunday that you struggle with. So you could go in and click on arrival dates Saturday and Sunday and filter it by then, compare, see where issues may be during the weekend hours. Maybe you're wanting to compare male versus female. If you want to go by race, or maybe how they arrived. You want to look at certain ambulance agencies in your area. Maybe one's, excelling and one's struggling just a little bit. So you can pull them up by agency. You can pull them up by the referral center, and you can actually pull them up by physician as well if you need to compare your physicians, and these are available in real time as well. Next slide, please. So coming soon, we will have full data reports for chest pain accreditation. We will have additional elements available to enter for CAD and ACS tracking. And then site-specific optional fields for data. Some facilities have certain data that they want to collect, and so it is possible to add optional fields for whatever it is that your hospital needs. Next slide, please. So in addition to today's webinar, we have one in 2 weeks on Wednesday, October the 4th at noon. And then we have another one on Tuesday, October the 17th at noon. And the third one on the 17th will focus on the STEMI referring hospital. So if you have any referral centers that you would like to maybe participate and Get with the Guidelines CAD, we encourage you to share this flyer with them, and we will focus on them because we know maybe that they might be interested in gaining recognition and awards as well, and getting those measures to their bedside, knowing that their focus is getting an ECG within 10 minutes and giving thrombolytics within 30, and then getting them door in, door out within 45 minutes on their way to you. So if you have some referral centers that are maybe struggling with that just a little bit, we encourage you to share this flyer with them. Or if they're doing great and you think that they deserve recognition, please share this webinar flyer with them as well. Next slide, please.
So thank you so much, Kristen and Ben, for your great presentations. We wanted to make sure that we have time to open it up for Q&A. All of our contact information is listed on this screen. Feel free to email any one of us with your questions if anything comes up after the webinar. If you want to ask a question, just feel free to come off mute. You can do that by hitting *6, not #6, but *6 to come off mute and ask your question. And then if you hit *6 again, you will go back on mute. You can also enter your written questions into the Q&A section directly into the webinar. So I'll give you a few minutes to either come off mute or enter a question, and we're happy to answer any of those that you have. Yeah, we can send them out to everyone. So someone has asked a question if we can share the slides with you after the webinar. We definitely will do that. We'll send it out to all of the attendees. So another question is, will webinar number 2 be different than the one that we've conducted today? So on that second webinar, we're going to do less of the overview and program changes and more of what the types of things that Kristen covered today, and going into more of the detail on actually utilizing the tool. And then one other clarification that I wanted to make sure to make is that this year during scientific sessions, we are going to honor all of our Mission Lifeline awarded hospitals. So if you are a bronze level hospital or silver or gold, we welcome you to come out to Anaheim, and we would love to celebrate with you. If you can send a representative from your hospital, whether you're bronze, silver, or gold, you're all welcome to come out. We have the save the date available, and we'll be sending out the details about registration for that event, and hopefully by next week. An additional question that came in was if we could elaborate on the chest pain accreditation capabilities of Mission Lifeline. So right now, hospitals that want to pursue chest pain center accreditation are entering their data into several different platforms. We have our leadership, American Heart Association and American College of Cardiology leadership met recently and decided that the Get with the Guidelines Coronary Artery Disease will be an allowed source for chest pain center data submission. So we right now have the ability for you to enter your STEMI patients, your non-STEMI patients, your ACS patients into the tool, and we are in the process of building out all of the measures that you will need for your chest pain center accreditation, the kinds of things that are included in the ACD tool now. That is scheduled. There is a plan for that to be ready to go by the beginning of the year for you. So if all goes as planned, it will be ready early 2018. Any additional questions from anyone on the line? Hit *6 to unmute yourself or type your question into the Q&A section of the webinar. So there's an additional question that was typed in. Is the data collection the same as the data for the Action Registry? And do we have a data collection form? So we're definitely willing to share the data collection form with you. You can send me an email request, Lonnie, LONI.den, DENNE, at heart, HEART.org. We can share that with you. In terms of the data being the same, so right now you're able to enter many of the fields marry up with the Action Registry. We have a few additional fields that are more related to your pre-hospital, what's going on pre-hospital. So things like, whether EMS notified your facility that they had a STEMI patient, and then whether you activated your system based on that information. Just a few things like that that are additional system-type data elements.
And Lonnie, too, on that, the data form, when you enter a patient, I know they're wanting the blank tool, but when you enter a patient, and you're done, you have the capability of printing that form, and so it comes out nice and neat and printed for those that keep a paper copy as well. Want to share those for review, so I have found that.
Thank you, Kristen. We have a question about how much it would cost to participate in Get With a Guideline Heart Failure as well. I am not as familiar, but we do have someone checking on that. So if we have the answer before we close out, we can talk about that. And if not, if you're able to send us an email, we'll get that pricing to you. But it's all of the pricing for our modules are similar. I believe it's less than Get With a Guideline CAD, and we subsidize our registries heavily to make participation in the registries more affordable. So, one of our QSI directors who's here in the room with us just pulled it up. It's $2,072 to participate in Get With a Guidelines Heart Failure. Thank you. Someone is asking if there is only one fee or if there are renewal fees for participating in the registry. The pricing that we had pulled up earlier in the webinar is for 2018. The tool is completely free for you to join and try out in 2017. Discounts are available if you sign up for 2018 by November 1st. And then each year there is a renewal fee. So the pricing for 2018 is just for use of the tool from January 1st, 2018 to December 31st of 2018. And then you would need to renew for 2019. Okay. Any additional questions? Okay, so it's 6 minutes before the hour, so we'll go ahead and close out. Please feel free to email myself or Ben or Kristen with additional questions. We're here for you. We hope that you're able to join us for our subsequent webinars. The next one will be held on October 4th at 12 noon Central Time. Appreciate all of your time, and thank you so much. Take care.